Mr. X, 55-year-old male, farmer by occupation, Hindu by religion, right-handed from Tilotama 11, was admitted on date 15 March 2022. Informant was patient himself and history was reliable. Was presented to UCMS TS with chief complaint of vomiting of blood since 9 days, yellowish discoloration of eyes since 7 days.
Okay.
Proceeding forward, in my history of presenting illness, my patient was apparently well 9 days back when he developed vomiting of blood, which was sudden in onset, coffee brown in color, occur in morning, 2 to 3 episodes, amounting 20 ml in each episode. It was unprojectile, associated with food particles, but not associated with abdominal pain, distension, and cough.
Okay. Uh, so is this hematemesis or hemoptysis?
This is hematemesis, sir.
How will you differentiate?
By the brownish color, sir. By looking the color.
Only brownish color. Any other things? Any other points to differentiate? So, okay, you told vomiting of blood which was sudden in onset. So this is coffee ground in color. You mentioned no? Coffee ground in color. Why it is coffee ground in color?
Due to acid hematine, sir.
Okay, so you have to ask for associated symptoms also. Anyway, you told associated food particles is there, no? So that will tell it is a hematemesis. Then for, if it is hemoptysis, you would have with cough and mucus also will be there, and frothy content will be also there. Okay, and it will be blood only, reddish color only. And you told 20 ml. 20 ml is how much quantity? Mild or moderate or severe quantity? How will you grade it?
20 ml.
20 ml means it's mild only. Okay, so usually till 50 ml we can consider as a mild. 50 to 150 ml it is moderate. So more than 150 ml you should be massive also. Okay, and also it depends on the episodes also. You told 2 to 3 episodes. So every day it was 2 to 3 episodes, or only during 9 days it was 2 to 3 episodes.
During in a session of 9 days episodes, or there were 2 to 3
So
episodes.
so every day it was like 2 to 3 episodes, or like different days.
So in 9 days there was 2 to 3 episodes.
Okay, okay. Then it's very mild only. Okay, it, so your inference of by this history is this is hematemesis. Okay, that is acute onset. Then onset will be sudden onset. So acute means it should be immediately. It is acute onset. Then what happened? He is not associated with abdominal pain. Distension is also not there. Cough is also not there. So then next.
After 2 to 3 days of this, patient started passing black stool 2 to 3 times a day, which was solid, shiny black with a characteristic cool smelling odor, non-painful, associated with fatigue, weakness, but not associated with dizziness or syncopal attack and dilbert at all.
So what is your inference now?
He is passing black stool as well, sir.
Now blackish stool spoons. What is that?
That means bleeding. Bleeding is still present, and that is passing through the stool.
Bleeding? Can
Yes,
you?
sir. That is melena.
This is proximal, no?
Yes, sir.
This is proximal. So you told vomit after 2 to 3 days. Why after 2 to 3 days he has passed black stools?
That blood may pass lately, sir.
Yeah. So it will take minimum 8 hours. Okay.
Yes.
Usually it will take 8 hours, and it is called as melena, no? Blacky color stool. It's called melena. So it is. It's by these two history. It's 100%. It is upper GA bleed. That is proximal to the distal of tegmental ligament. Okay. So and you told so to pass blacky stools, how much ml of blood should be bled?
More than 50 ml, sir.
Yeah, more than 60 ml usually. Okay, more than 60 ml. So by you are telling after 2 3 days, so 20 ml 2 to 3 episodes exactly. More than it may be 60 ml. That's why he has passed. Okay, but you told foul smelling order. Usually it won't be foul smelling order. It will be normal only. So non-painful associated with fatigue. Okay. Then No, what is the causes of hematemesis?
Generally, the cause of upper GI bleeding, sir.
No.
In upper GI bleeding, malaria was here,
Hmm.
and
You should tell most common causes first. Most common cause.
peptic ulcer perforation, sir.
Yeah, peptic ulcer disease. Then
stomach ulcer, peptic ulcer,
oh,
and Barrett esophagitis,
okay,
esophageal varices,
okay.
and malaria was here.
What? Once again?
Malaria was here, sir.
Okay.
And if there is carcinoma, there might be bleeding as well. So
Hmm.
gastric carcinoma.
Okay.
And gastric TB.
Gastric.
Gastric TB.
Okay. So, what is hematochezia?
Hematochezia means, sir, if that is maroon blood stool, sir.
No, hematochezia will be frank blood almost. Okay.
Yes,
so it is distal to the ligament of
ligament
treads.
teres. Yes, sir.
Yeah. Then
if distal to that, if there is any bleeding, then that will present as a hematochezia, sir.
okay. Then so how will you differentiate upper GI bleed and lower GI bleed?
In lower GI bleeding, the volume is more on the basis of color of stool, sir.
Can you hello? Can you hear me?
Yes, sir.
Is very low.
And now is it audible?
Yeah.
Is it clear now? Then
Yeah, it's clear.
in lower GIT, sir, there is clot present, and the color is also different. In upper GI bleeding, the color is blackish. In lower GIT, there will be
No,
clot of blood.
Okay. Upper GI bleed, if it is coming out of mouth, it will be normal red and black color, this brown colored also, and black color stools during rectal bleeding. Okay. So anyway, causes of usually hematemesis, most common causes duodenal ulcers, then gastric ulcer, then acute gastritis induced drugs, then after that malarial syndrome, gastric carcinoma, then esophageal varices. These are the causes of upper GI bleed. So if upper GI bleed, that 60 ml of blood is present in more than 8 hours, then it will pass as black colored stool. That will melanine cause. So hematochezia means this passage of directly rectal bleed. It may be because of rectal carcinomas, hemorrhoids, and all those things. Okay.
Okay, sir.
Okay. Then that amount is very important, blood loss amount. So if it is till 500 ml, there won't be no systemic signs and all. If it is 1000 ml or 2000 ml, then they will have tachycardia and they will end up in shock also. Okay. So that is very important. Immediately. Okay. Hello.
Yes, sir.
Okay. By this history, this is the upper GI bleed. That is the inference. Then next, what to do next? You can continue.
Patient also gave history of yellowish discoloration of eyes for last 7 days, which was insidious in onset, slowly progressive. Initially appear on the sclera, later involved skins of limbs and abdomen.
Okay. So
Patient, yes,
yellowish discoloration of eyes. That means what is that called term? Jaundice.
discal
Anyway.
jaundice, sir, icterus.
Okay. Jaundice. So how much bilirubin will be there if it yellowish discoloration of eye sclera is visible?
More than 2 mg per decil, sir.
Yeah, more than usually 2 mg. So what is latent jaundice?
Latent between less than 2, more than 1.
Yeah, 1 to 2. It is latent jaundice. It won't be visible. Only blood investigations we can get to know. So first, yellowish discoloration, usually it will be affected to sclera. Then it will involve all other parts. Okay. So it's definitely 7 days means it's very acute onset of jaundice. So what will be the causes of acute onset of jaundice?
And the acute causes of jaundice are uh, hepatitis, sir.
Yeah,
And
first hepatitis. Okay, hepatitis. So what hepatitis? Why so many hepatitis are there?
viral hepatitis, sir.
Okay, then
And hemolysis.
okay. So we can differentiate three types of jaundice, no? Hepatocellular
Yes,
jaundice,
sir.
hemolytic jaundice, obstructive jaundice. Usually hepatocellular jaundice, which color will be there?
In hepatocellular, sir.
Hepatocellular jaundice.
There will be
Sclera will be high sclera will be orange tinged. Okay. So in hemolytic jaundice is mild yellow tinge. Okay. In obstructive jaundice, it will be greenish yellow, almost like skin and sclera will be greenish yellow. We can differentiate by that also on examination anyway. Okay. Now in the okay, yellow is discussion of 7 days. Then acute onset of acute causes. What first most common cause is viral, you should think. Then drugs. Drugs is the almost drugs and toxins. Okay, very 7 days, no sudden onset. So drugs and toxins we should think of. Okay, then hello. You
yes,
can
sir.
continue.
Yes,
Now,
sir. Okay. A patient also complain of burning and irritation sensation in eyes, skin and body. Also complain of yellow color urine. However, he had no history of itching in the body, confusion and aggressive behavior.
okay, burning and irritation sensation of why. What is your inference?
If the bile salt is regurgitating into the blood, then that might cause irritation in the
Yeah,
skin and the eyes.
yeah. Okay, so yellow colored urine. So yellow colored urine is there. Then
Yellow color means the passes of bilirubin in the urine, sir.
yeah, yeah. So usually, if yellow colored eye, that you should ask. Yellow color is normal. You should ask eye colored or dark colored. Okay, you have to ask when the patient tells no yellow color, you should it is too high or it is too dark like that. So if it is too high, we have to think of hepatocellular. So if it is dark colored, then you should think of any obstructive jaundice, gallstones or anything like that. But in hemolytic jaundice, the color will be colorless. They won't be high colored or dark colored. It will be colorless. Okay. Then pruritus, itching is if itching is there, then you should think of obstructive jaundice, more of
Yes.
obstructive jaundice. If itching is not that much, it may be hepatocellular. But in hemolytic jaundice, itching won't be here. Okay. So and you should ask for stools also in this associated stools. Did you ask for stool color?
No, sir.
Yeah, a stool. It will be in hemolytic jaundice. Stool color will be normal only. But in hepatocellular jaundice, it will be little pale. Then in obstructive jaundice, it will be clay colored. Okay.
Yes, sir.
Okay. So there are three things. The onset is also important, and the associated symptoms also important. You have to ask all these things to differentiate which type of jaundice it is. And definitely is acute jaundice. It may be hepatocellular also because almost he has burning pruritus also is there, but not that much. That the burning and irritation sensation almost like it's pruritus only. And confusion and aggressive behavior. What is why you asked confusion and aggressive behavior?
If there is any liver pathology or something else, then what happens? There is production of ammonia that might cause the that might cross the blood-brain barrier, and that might cause hepatic encephalopathy. To rule out that thing, I have asked confusion and aggressive
Oh,
behavior.
okay, okay. Hepatic encephalopathy. Okay, fine. Next. So by this history, what is your inference? There are two positive histories. One is upper GA bleed is there.
Yes, sir.
Second point is this is jaundice is there. Jaundice means so it may be liver pathology. Okay, liver pathology is causing both these things. So what is your inference?
Uh, there is correlation between hepatic and upper GI bleeding, sir.
Yeah.
So
So there are hepatocellular involvement is also there, and portal vein involvement is also there. So there
yes,
are
sir.
hepatocellular and portal vein, hepatosystem and portal system. No, both systems are involved. So, so to cause bleeding, what should be the portal venous pressure?
More than 10 mm of Hg, sir.
More than 12 to cause
12, yes,
bleed. Okay,
yes,
more than 12. Okay, and jaundice is there. So hepatic impairment will be there definitely. So it's the acute cause. It is not chronic, no? Within 7 days, you are telling. Is
Yes,
it
sir.
acute or chronic?
Sir, it is chronic because he has similar illness in the past as well, sir.
Okay, okay. You are telling in the past history. As of now, as per this history, it is acute. Okay,
Yes, sir.
okay. Then next,
In negative history, no history of joint pain, rashes, petechial bleeding, spots over the limbs and body. No
why
history
you
of
ask
pain.
this history? Why you ask this history?
Sir, joint pain to rule out systemic causes, and for to rule out viral infection, I have asked him about rashes and petechial bleeding.
Joint pain, you should rule autoimmune also. Autoimmune disorders, autoimmune cause of liver damage also. Okay, rashes. Why rashes?
To viral infection, viral hepatitis.
Yeah, not all. Okay, viral hepatitis. Okay, then
Petechial
petechial
bleeding
bleeding. And yeah,
and spots
petechial
over the
bleeding is, yeah. Why it is important?
uh, if if there is any.
Now, petechial bleeding usually it will have petechia and ecchymosis will have any coagulation defects or
Yes,
thrombocytopenia. So coagulation defects means liver has or liver functional liver function can be if coagulation defect is there and liver function is damaged, we can understand. And if spark the thrombocytopenia is there, then hypersplenism happening. Those splenomegaly is also there. So for that we have to ask and to rule out portal hypertension also if splenomegaly and all is there like that. Okay. Then next one,
to no history of pain and swallowing and lump in the throat.
why it is why you asked this one?
If that to rule out upper GI bleeding is from the uh, oral cavity or from the
Okay, I think there is no need of rule outing this because already you are telling this melena is there, no?
yes, sir.
Anyway, yeah, melena is there. It may be because of is that esophageal varices only. Okay, you can ask that anyway, upper GI bleed, and you can rule out carcinoma of esophagus also, esophagus or
Yes,
throat laryngeal carcinomas also. Okay, then
no history of fever, cough, difficulty in breathing, chest pain, orthopnea, and PND.
okay, why you asked this thing?
Uh, Fever to rule out hepatitis, viral hepatitis infection, uh, and
Okay.
and cough. Either there is uh,
Okay, to rule out any respiratory tract infection or any
yes,
carpal mail, anything like that. Okay, difficulty in breathing, chest pain, any congestive heart failure. So
yes,
congestive heart failure also can cause congestive hepatitis. Okay, in that time also jaundice can happen. Okay, liver failure can happen. So to rule out serious causes. Okay, then next one,
orthopnea and PND.
yeah, orthopnea, cardiac failure, same thing.
Yes, sir.
Next one,
No history of IV drug abuse, tattooing.
why it is important?
Hepatitis B is highly vulnerable
Yeah,
to this thing, sir. So I have asked about this thing.
okay, then
No history of recent travel to abroad.
okay, why it is important?
Same things are viral infection or an infection.
Okay,
If
what all infections are you thinking?
hepatitis B, hepatitis A, and C, sir.
Okay, then EBV virus, CMV virus also you can
Yes, sir.
think of. Okay, then
No history of frothy urine, bonding micturition, increased frequency of micturition.
okay, why frothy urine?
Frothy,
Where will you see frothy urine? Usually if proteinuria is there.
if proteinuria is there, then we can see
Uh,
that thing, sir.
Yeah, proteinuria is there. You have to ask for that.
Yes,
Okay,
sir.
and burning micturition to rule out recurrent UTI and all. Okay, fine. Okay, next.
In past history,
No,
similar history of
you have to ask for abdominal distension history. You missed abdominal distension. Okay. And did
yes,
you
sir.
ask abdominal distension and pain abdomen is very important. No, pain abdomen is very important in
Yes,
acute
sir.
history. So any gallbladder stone, so cholelithiasis, anything is like that. Any massive splenomegaly, you should rule out. No, and also pain abdominal distension is required. In chronic liver disease, ascites will be there. No, so that is the. So what is the triad of portal hypertension?
Total, sir.
There is a three things, triad, characteristic cardinal things.
Yes, sir.
If portal hypertension is there, upper J bleed will be there, then
Yes, sir.
ascites will be there, and splenomegaly. Okay, this is the triad of portal hypertension. Okay, okay, you should ask for abdominal distension and pain abdomen. That is very important. Okay, next.
In past history, similar history of bleeding from mouth is settled with abdominal distension and yellowish discoloration of body nearly 8 months back, for which he visited UCMS TS and improved after admission.
Okay, now at present there is no abdominal distension.
Yes, sir. There is no abdominal
Is there
distension.
is there abdominal distension? It's not there.
Yes, sir. There is no abdominal distension.
Okay, then how it has decreased?
Weight not decrease, sir.
No, last eight
Slightly.
months back you told 8 months back you told abdominal distension is there. No, 8 months back it
Yes,
was
sir.
there. Now
Yes,
how
sir.
it improved? What will be the cause for improvement? How they have treated any? So they would have tapped. No, they would have
Yes,
removed the
sir.
fluid, or they would have given diuretics and all. Okay,
Yes, sir.
okay. So 8 months back it means it may be chronic only. So when you will call chronic liver disease,
After 6 months, if the liver function deteriorate more than 6 months, then we can say that is chronic liver
yeah,
disease.
almost okay. Almost all the symptoms, all the diseases will be acute will be till 4 weeks. Subacute will be 4 to almost like 12 weeks. Then almost like more than 12 is chronic only. Usually 6 months, more than 6 months. Okay, it's okay. So it's almost like similar problems. Only one time he has admitted, and 2 or 3 times.
So only one time, sir.
Okay. Okay. Did they operated him on anything banding? Anything they did they do?
No,
Any
sir.
history of surgery?
No, sir. There was only diuretic given, drainage of ascitic fluid, and he was sent home.
Okay. Okay. Then
No history of hypertension, diabetic mellitus, pulmonary tuberculosis, ischemic heart disease in the past.
okay.
No history of high risk behavior. No history of
o-
surgical intervention.
Okay. What surgical intervention they will do? Bleeding
Yes,
from
sir.
mouth. Hematemesis is there usually.
In past history, sir, there was
No,
no
no, no.
bleeding.
I'm asking what surgical intervention usually they will do.
Sir, poto, poto sounding, poto travel
Yeah,
sounding.
venous shunting and usually nowadays banding, easy banding. That esophageal varices will be there. No, they will band endoscopy. They will band that. So if banding also is not feasible, then they will go for shunting, tips and all shunting. Okay, and he was okay. Then you can continue.
In personal history, he consumed mixed diet. Intake of food decreased in 7 days. His
Did you do you tell drug history next? No, or here only?
sir, drug history, sir.
No,
I
he is not taking any treatment.
sir, you have left since 1 month, and then he again complain of this thing, sir.
No, what tablets he was taking?
Sir, he was taking diuretic, sir, and
Hmm.
uh, he was taking only diuretic, sir. Now recently,
Okay, so if
and
bleeding is there, we should add which drug?
anticoagulant if he's taking any
No, no,
anticoagulant.
no. Not anticoagulant. We should add beta blockers. No, we
Yes,
should
sir.
have beta blockers to prevent it. There is a prophylaxis. Okay. So for bleeding, you told already it's bleeding is there, no, from 8 months.
Yes, sir.
So you should lifelong. You should take for that. Okay. Okay. Then next you can continue.
In personal history, he consumed mixed diet. Intake of
Mm,
food decreased in 7 days. He is
mm,
chronic alcoholic for last 20 years. Back, he
mm.
consumed about daily 150 to 200 ml. Now he left since 2 years. No history
So
of smoking.
how will you calculate serogenic quantity of alcohol? What is 1 unit of alcohol?
10 gram of alcohol, sir.
10 grams of alcohol. So what is the normal limit of alcohol?
Normal limits are 150 ml in a week. 150 200 ml in a week.
Yeah, around, yeah. So for males, it is 21 units, around 21 units, not ml. You can tell 21 units. That is 210 ml around. Okay. For females, it is 14 units per week. That is a normal limit. If it is double than that, that is around like 40 units, 40 to 60 units, then you will be a high risk for cirrhosis of liver. Okay, so you should calculate that. So different types of brands, they will have different units of alcohol. 1 unit of alcohol is 10 grams of alcohol. 1 unit is equal to 10 grams of alcohol. Okay.
Okay, sir.
Okay, that you have to ask proper alcohol history. In this case, I think it's not necessary. If patient is already taking alcohol, there is no any early symptoms, you can guide them. Is it a serogenic quantity of alcohol or not? Okay, so that's why limit is important. Okay.
Okay, sir.
Now left since 2 years. Why you left since 2 years?
Family member has left him in this, sir. Yeah, he
No, you
was.
should ask for that history properly because the symptoms started 2 years back or anything like that. We'll get to know. If symptoms start, no, liver failure symptoms start. If any hematemesis is there, you should go back and ask history properly because you told 8 months back he was admitted. No, before 1.5 years also, did he have all these symptoms and all? You should ask. After that only, usually alcoholics will leave the habit of taking alcohol. Okay.
Okay, sir.
Okay. Then,
He has no history of smoking, altered sleep pattern since 9 days, sir.
so okay. What is your inference? Altered sleep pattern.
Sir, there is a grade 1 hepatic encephalopathy.
Yeah. Usually, this is a early symptom of hepatic encephalopathy. And they will have daytime sleepiness. Okay. Usually daytime sleepiness, nighttime they won't. What is the early sign of hepatic encephalopathy? This
Early
is a
sign, sir.
symptom. Early sign. Early sign will no.
Aggressive
Early
behavior.
sign no. Early sign is so any chronic liver disease patient comes for your follow up. No, you should ask for this history to look for is there any starting early stages of hepatic encephalopathy is there. Then you should ask for altered sleep pattern. Then you should
Yes,
check
sir.
for constructional apraxia. What is constructional apraxia?
Difficult. His speech is either.
No, constructional apraxia. You have to structures to make structures. Okay, by pen or you give him some simple structures to circle and to write circle or to draw triangle, anything like that. So usually if they are not able to draw that, that is a early sign of hepatic encephalopathy. We can predict that and we can prevent the hepatic encephalopathy. That's why all the chronic liver disease patients who comes for follow-up, no, you should ask all this history, altered sleep pattern, and this early signs also you should check. If it is there, we have to treat early only. Otherwise, by that we can prevent the hepatic encephalopathy. Okay.
Okay, sir.
Okay. Next.
In family history, as there were 7 members in the family. No history of similar illness in the family.
Okay. Usually, what disease will be in the family in liver diseases?
His patient, his family member is taking alcoholic or not? We can rule out that. And
so many causes, congenital
yes, sir.
jaundice.
Congenital.
Yeah, those things and all is important. Krigler-Najjar
Yes, sir.
syndrome, some Gilbert syndrome, Rotor syndrome, Dubin-Johnson syndrome, then hemochromatosis, Wilson's disease. Those are all the causes of chronic liver disease. No, you have to write. Whenever the patient tells alcoholic, we should we should quantify alcohol. Is it a serogenic alcohol? Is it causes cirrhosis of liver or not? If it is not, that quantity is very less, then you can't label him as alcoholic liver disease. Okay, you have to look for other causes also. If patient just listen, if patient is taking only 30 ml per day, okay, 30 ml per day is very less. Okay, no, 10 ml per day, like that. 10 minutes, sorry, 10 grams per day alcohol. That is 1 unit per day. It will per week, it will be 7 units. It is safe, but he developed chronic liver disease. That time, you should not label him as alcoholic liver disease. We should rule out other causes also. Okay.
Okay, sir.
Yeah, so you should quantify that, and then only we can label it. Sometimes if genetic predominance and all is there, mild alcohol can cause also cirrhosis of liver. Okay.
Okay, sir.
Okay. Next.
In socioeconomic history, he lives in one storied Paka house with just a tin on the roof, drinks water from tap, has a toilet at home 50 meters from the house, belongs to low middle class family.
Okay. Drinks water from tap water means it may be infections also. So
Yes,
maybe
sir.
liver disease, those things and all we should rule out. Abscess. So that's what. So this is very, and he is almost like low economic family. So low economic family, tuberculosis is very common. So it can also cause serious or disseminated tuberculosis also can cause portal hypertension and lymphomas and all. Then they can have cirrhosis of liver also. So you should rule out also. Why is socioeconomic history is important?
Uh, because the disease might relate to that. Disease might related to these things, sir, and
Yeah,
this
and this is also might related and very important for
nutrition.
treatment.
Yes, sir.
Treatment also. So you can't. There is a drugs which can give very less cost also, and we can plan the treatment also. Are they affordable or not? Those things and all very important. You can't. So there will be drugs for high prices also, low prices also. Like that, we can assess the economic status of the patient and we can treat them accordingly. Okay.
Okay, sir.
Okay. Then you can
Drug and
continue.
treatment. Drug and treatment history. He was treated with similar illness 8 months back. No history of anticoagulant. No allergic to drugs given till date.
Yeah, that's what. No, if social, if is low economic, we can you could have given propranolol tablet that costs very 50 paisa per one tablet. That could have and prevented is now second episode of hematemesis. Okay, so they would not have given that is so propranolol is very less costly. Then another drug will come cardioselective carbidomal. It will cost more. So that's why socioeconomic history is important. So drug and treatment history is not taken means. So it's our you should you should make patient to take these drugs. Otherwise, he will end up again with a similar complaints. Okay.
Okay, sir.
Okay. Is the patient was non-compliant or they didn't prescribe any tablets? You should ask for that also.
Yes, sir. They were prescribing, but he left before
Yeah, yeah.
months.
That's a non-compliant. So you have to counsel him properly. So according to socioeconomic status, we should give proper tablets for him. Okay.
Okay, sir.
Okay.
Now, summary. Mr. X, 45-year-old male, resident of Tilotama 11, had a history of chronic alcohol consumer, presented with chief complaint of blood and vomiting and yellowish discoloration.
Okay.
With this, my differential diagnoses are chronic liver disease and congestive heart failure.
Congestive heart failure, why?
Because sometimes the congestive heart failure might cause this
No, no,
this
no. It won't be a second, okay? So the congestive heart failure, you can't tell like that. Yes, he doesn't have any breathlessness, nothing is there, no?
yes, sir.
Chest pain, breathlessness, palpitations, nothing is there, heart related. So it's just a chronic liver disease with the very portal hypertension also is there, no complication.
Yes, sir. Yes, sir.
And it may be early stages of hepatic encephalopathy also because there is a so chronic liver disease complications are there, no? What are the
Yes.
complications of chronic liver disease?
Total hypertension, jaundice, spontaneous bacterial peritonitis, uh,
Mm.
and
Jaundice is not a complication. Okay.
yes, sir.
Okay. That is a sign. A sign. Okay. Complications of chronic liver disease.
Ascites,
Okay. In portal hypertension, ascites will come. Anyway. Okay. Portal hypertension, ascites. Then hepatic encephalopathy,
esophageal varices, sir.
uh, esophageal varices. In portal hypertension, that is a triad. No, it will come.
Yes, sir.
Okay.
Yes, sir.
Hepatic encephalopathy, spontaneous bacterial peritonitis, hepatorenal
Hepatitis,
syndrome,
yes, sir. Hepato,
hepatocellular carcinoma,
hyper,
coagulopathy,
yes, sir.
hepatopulmonary syndrome, then
Yes, sir.
malnutrition disorder and bone disorders also. And hematologically, usually anemia, neutropenia, those things will be there. So you should ask all this history in your these complications also. You should ask because you know all these is already known case, is already taking this case. No, you should do the complications. For portal hypertension, you can ask two things: abdominal distension and vomiting. For ascites, for hepatic encephalopathy, aggressive behavior, whatever you ask, no sleep pattern and all. Spontaneous bacterial peritonitis, what all history you will ask?
Abdominal pain.
Abdominal pain, fever.
Yes,
Okay.
sir.
Then hepatorenal syndrome.
In hepatorenal syndrome, if there is a pro- even
Usually refractory ascites. Ascites won't be resolving. Okay. You will tell that whenever they will tap again, the fluid is reaccumulating. Okay. With the diuretics also, patient won't be. So that is one of the symptom of hepatorenal syndrome. And hepatorenal syndrome, one more thing, oliguria, urine will be less.
yes, sir.
Okay. So hepatorenal syndrome, functionally, structurally, kidney will be normal, but functionally, it will be won't be functional because of hepatic failure. Okay. What is then hepatocellular carcinoma? What all history you will ask?
And hepatocellular carcinomas are
You should ask for anorexia, loss of weight,
yes, sir.
usually malnutrited. Okay. Any abdominal mass, sudden mass. Okay. Those things and all you should ask. Coagulopathy.
If there is any bleeding disorder,
Yeah.
like
Petechia, bruising.
yes,
Okay.
sir.
So bleeding like this. Then hepatopulmonary syndrome.
Shortness of breath.
Yeah. Shortness of breath. Okay.
Yes, sir.
Okay. So you should ask all this complication history. Then in the summary, you can tell. So patient is a chronic liver disease, query secondary to alcohol because its quantity is almost like serogenic. Okay. Serogenic of quantity alcohol, query with portal hypertension. So, but second cause can be, I think, is a direct case. There is no second also. But if it is not a serogenic, then you should think of other Wilson's, hemochromatosis and all. If Wilson's is there, what all history you will ask?
Uh, that copper intake. Any
You history में usually they will have Korean movements and all those things and all you should ask. Okay,
yes, sir.
Korea movement you know. So abnormal movements of the hands and all. Okay, Wilson's hemochromatosis and all. They will have black colored stools. So iron overload things. Okay, skin pigmentation, hyper skin pigmentation. Those things and all you in history you to ask. And any family history also. In family also, any liver function, liver disorder patients are there. We should ask for that. Okay, in primary biliary cirrhosis, usually primary biliary cirrhosis, it will be like pruritus will be more obstructive disorder. No, pruritus will be more. Okay, they won't have portal hypertension and all. Okay, that not much of portal. If it is a cholelithiasis, obstructive causing a liver failure and all, then they will have pain abdomen, those things and all. Okay, so congestive heart failure you can't tell here. Okay,
Okay, sir.
okay, you can continue.
Now moving forward to examination portion. On my general survey, patient was lying on the bed with IV cannula on the dorsum of the right hand. He was oriented to time, place, in person.
Okay, so on this actually you can tell about the uh, is built also. How was is built?
Sir,
Malnourished or
average build, sir.
average? No, malnourishment is very important. Malnourished or because is he going for hepatocellular failure? They will have what type of pace?
Congested face, sir.
No, hepatic phases they will call. No, what is that called? They will have sunken eyes. Okay, hollowness will be the temporal bowels will be there. Okay, those things and all is there. So built is very important. You should mention about the built also. Well nourished or how he is built under. Okay, conscious oriented time place and means he is not in hepatic encephalopathy grade 2 or grade 3. Is conscious finely. Okay.
Okay, sir.
Okay. Then
And on vitals, pulse, The pulse was 80 beat per minute, just regular, normal in volume and character, without radio-radial delay, no
Mm.
radio-radial, radio-femoral delay. All peripheral pulses were palpable.
What is your inference?
So, heart rate is
So
normal,
pulse
sir.
is normal, heart rate is
Yes,
normal.
sir.
So that upper J bleed is not that massive or maximum. It's mild only. Because if it is massive, you would have tachycardia, high
Yes,
volume
sir.
pulse. Those things will be there. So it's normal only. Okay. Then BP is okay. Then you continue.
On blood pressure was measured on left arm, was
Mm.
120 by 70 millimeter of mercury. Uh, Measure on left arm on supine position, and on respiratory rate was 18 breath per
Why
minute.
you measure? Why you measured on left arm?
Sir, there was cannula on the right hand, sir, so I measure on left hand, sir.
Okay. Okay. Usually you will measure on right hand only, no? Right.
Yes,
Right
sir.
arm. Okay. Okay. In CVS examination cases, you should measure all the limbs. Okay, right, left, and lower limbs also. In normal other cases, it's fine only. Okay, then.
On respiratory rate was 18 breath per minute, and the
Hmm.
respiration was thoraco-abdominal.
Okay, why it is important thoracoabdomen? Usually,
Uh,
if it is abdominal distension was there, massive abdominal distension, usually it will be abdominal thoraco. Okay,
Yes, sir.
okay. So okay, next.
Temperature was 98.6 degree Fahrenheit, and
Hmm.
uh, and oxygen was 96%. Saturation of oxygen was 96%.
You should mention on room air or on oxygen. You should mention that also. SpO2 96% on room air. Okay.
Okay, sir.
So as vitals are stable only. He doesn't have any tachycardia. He doesn't have any hypotension or hypertension. He doesn't have any tachypnea also, and he doesn't have any fever also. And his saturation is also fine. So patient is stable. He doesn't have any. What all complications we can rule out now here?
There is
On seeing these vitals,
no portal hypertension.
portal hypertension. How can you tell by this?
This
You can't tell
complication.
about. So
Yes, sir.
you just tell that he is not in shock. Any bleeding, hemorrhagic shock is not there, and tachypnea is there, not there. So hepatopulmonary syndrome we can rule out. Temperatures, fever is not there. So spontaneous as of now, at present, we don't know history. Earlier it was there and all as of now. So SBP also we can rule out. No infection and all. Fever is not there. Okay.
Okay, sir.
Okay. Next.
On general examination, pallor was
Mm,
present, icterus present, no palpable lymph node, no cyanosis, no clotting, no
mm,
koilonychia, petals, petal edema, and there was mild dehydration.
okay. That's all the general physical examination. Other things.
Yes, sir.
What all
Spider
things you can see?
Yes, sir. We have to look for spider navy,
Mm.
and spider navy was present 1 to 2
Okay,
pieces.
when you are seeing general physical examination, no, you should come by head to toe. From here
Yes,
to start, you have to start from air. Obvious is air. Air is fine, no? There is no loss of air and all, no?
yes, if
Usually,
yes, sir.
uh, tell me,
Sir, there was no loss of air.
loss of air was there or not?
Not, sir. Not
Okay, there is
present.
no. So alopecia, alopecia is one of the sign of liver cell failure. Okay, so you should. He is a chronic liver disease patient. You should look for hepatocellular failure signs. Okay, is there any alopecia? Alopecia is not there.
Yes, sir. There was no
Okay, then
alopecia.
then
Then and then we have to look for pallor and icterus.
okay, pallor is there.
Yes, sir. There was pallor.
Okay, pallor is there, anemia is there. So because of
Yes,
blood loss or nutritional deficiencies. Okay, then icterus is present, jaundice. How will you see pallor?
sir. Pallor will be seen on lower palpebral conjunctiva, sir.
Icterus.
Icterus on upper bulbar conjunctiva, sir.
Okay, very good. Then okay, then
Lymph node. There was no palpable
okay,
lymph node.
okay. What lymph node will be usually GAT malignancy? Some lymph node is named lymph node is there, no? What is that?
Sir, that is inguinal lymph node.
Left supraclavicular node. Usually in
Yes,
GAT malignancy or pelvic malignancy, that is called Virchow's node. Okay, that's one of the named nodes. Okay, that is a left supraclavicular node. Okay, then cyanosis node there. Clubbing, where you see clubbing in
Uh,
liver diseases?
clubbing, sir, in fingers, sir.
No,
Looping.
no, I know. What are the disorders in related to liver diseases? Usually in chronic Crohn's disease, ulcerative colitis,
Yes, sir.
sometimes primary biliary cirrhosis. There else you can see clubbing. Okay,
Yes, sir.
okay. Cholinergia. So there is no iron deficiency. Cholinergia is not there. There is no iron deficiency. So then, which one more thing you should see. What is leukonychia? Can you hear me? Hello,
Yes, yes,
Ravi.
sir. Yes, sir.
Leukonychia means white nails. It's a classical sign of liver cell failure because of hypoalbuminemia. So cells nails will be white. Okay, that is leukonychia. Okay, you should look for and pedal edema. Pedal edema, liver cell failure, bilateral pedal edema will be there. Okay, so will it be pitting or non-pitting?
It was non-pitting type, non-pitting type of edema, sir.
Usually it will be pitting. Okay, you should check for properly. Okay, pitting pedal edema. Okay. What are the causes of pedal edema and bilateral lower limb swelling usually?
Normally, physiologically in the pregnancy, sir.
No.
And, and
Then all system failures, congestive heart failure,
sir,
chronic liver disease, liver cell failure, and kidney failure also, nephrotic syndrome also. But the
yes,
pattern is very important. Usually in chronic liver failure में abdominal distension will be first presentation. Then pedal edema will be present. Okay. In kidney problems, nephrotic syndrome, and facial puffiness will be there, and periorbital swelling will be there. After that, pedal edema will be there. In congestive heart failure or RS causing carpal tunnel and all, no, their
yes,
first presentation will be bilateral pedal edema will be there. So actually in history you should ask this bilateral lower limb. In history you missed it. In history you should ask this abdominal distension and bilateral lower limb swelling. No, the pattern you should ask. Okay, which started first we can get to know. Okay, dehydration you told, no, dehydration is present.
yes, sir. Mild dehydration was present, sir.
Okay, if dehydration you should think of is you should optimize the diuretics tablets also. If you are giving diuretics and all, then if he is having hematemesis and all, you should think of. But dehydration is present, tachycardia is not there, hypotension is not there. It won't be sinking, no. So mostly you won't have dehydration also. You should properly look for that. Okay.
Okay, sir.
Okay. Next.
Spider navy was present, and there was no palmar erythema.
Now, what is
There was
spider navy?
spider navy means,
Did you see the spider navy?
yes, sir.
Because spider navy, it's very difficult. In this case, patient doesn't have gynecomastia, loss of spider navy significance because of increased circulating estrogens. Okay, it will be.
Yes,
You mentioned palmar erythema is not present, loss of axillary not present, gynecomastia is absent, testicular. So there is no hyperestrogenemia signs, but only spider navy it won't be present. That's a very rare sign. Okay, it may be normal petechia. You should make out how it will be spider navy.
sir. We have to look for any. Uh,
No, did you take photo of that patient spider navy?
no, sir. I haven't taken that photo, sir.
Okay, spider navy usually be central arteriole with radiating vessel. Classical vessels will be there, just like a spider. Okay,
Yes,
actually
sir.
it won't be able to visit by normal eyes. We should focus and see that. Okay, it won't be a spider navy. Usually if spider navy is present, then all these symptoms should be present. Gynecomastia, loss of axillary, those symptoms. If they are not present, spider won't be present and spider navy won't be present. Okay, so it may be normal petechia or anything like that. Okay, you got my point.
Yes, sir.
Okay, but is it spider navy normally seen or not?
Normally not seen, sir. In
No, normal in healthy person, in 2% of the population, it normally seen also. Okay. And also in pregnancies. Okay. But
okay,
when will you call it as abnormal?
sir. If The value exceed more than 2, sir.
More than 5. Okay, it should be more than 5 to see it is abnormal and to indicate liver disease. Okay, it's if it is 1 to 2, it may be normal also, and it won't be a spider maybe also. We should see and we should take a photo of that. Okay.
Okay, sir.
Okay, then.
Palmar erythema, there was.
Okay, you missed. Okay, palmar erythema. Okay. Oh, okay. So parotid gland history you should ask earlier only. From head to toe, when you are going from head to toe, no. So you should go like that only. So the parotid swelling. So if there is no parotid swelling, then loss of axial layer. Okay. Gynecomastia, testicular piece should come. Okay, you continue. In orderly only you should write. Okay, when you are writing.
Okay, sir. There was no testicular atrophy. Flapping tumor was present, sir.
Okay, flapping tremor is present. Then what is the grade of hepatic encephalopathy?
Sir, grade 1, grade 2, sir.
Usually grade 2. Okay. So
Yes.
grade 2 may flapping tremors will be there. That is called an asterixis. So what are the causes of flapping tremor?
In recipe, in the case of COPD, sir.
No, COPD, okay, CO2 narcosis. So almost all encephalopathies, any metabolic encephalopathy like CO2 narcosis, hepatic encephalopathy, in kidney failure, uremic encephalopathy, in metabolic like hypernatremia, sodium is high, hypernatremic encephalopathy, hyponatremic encephalopathy, and hyperglycemic encephalopathy, hypoglycemic encephalopathy, almost all encephalopathies. Yeah, in COPD, CO2 narcosis, there you can see flapping tremors. Okay. How will you demonstrate flapping tremors?
By patient to ask the patient to put the and if the pain any tumoring like that, then we can demonstrate flapping tumors, sir.
Okay, okay. Okay, we should see the moment of metatarsus, like moment of the first like we should flapping of the fingers. You should see, not a tremors like this. It should be forward flapping. Okay.
Yes, yes, sir.
Okay. Next.
There was no PTC, no fetor hepaticus, dupliceal contracture absent. Deeper venous pressure was not palpable. After hepatojugular reflex, I feel there was jugular venous pressure.
No, you can't. If it is hepatojugular reflex is present, then right heart failure also you should think of. Okay, so you should make properly. Okay, I think in this case it won't be present also because it doesn't have any right heart failure symptoms. Okay, pedal edema is present. It may be there also.
Okay, sir.
Okay, then what is fetor hepaticus?
Fetor hepaticus means if the liver is not filtering the detoxifying the agent, then that will go to the lungs, and the product will be extracted out from the lungs. So we can smell that product on the expiration.
Yeah, that a fecal smell of breath similar to the dead rat. Okay, because of it is a methyl mercaptan, no, and it is derived from methionine. So those amino acids, because of that, it will be, usually it will be seen hepatocellular failure. Okay. Okay. Next.
On systemic examination, on GI system, oral cavity examination, lips, teeth, gums were normal, cheeks, buccal mucosa normal, tongue ulceration lesions absent, palate normal movement, floor of the mouth normal, breath halitosis absent.
Okay. Usually we should think see for any ulcers or any inflammation, glossitis and all, any nutritional deficiency or their vitamin B deficiency, those things and all you should think. Okay, glossitis. So if it is not there, it's fine. Okay. Next.
On for abdominal examination, on inspection, shape of abdomen not distended, no venous prominence on sitting and standing position, while a patient asked to cough, and umbilicus is in central position, midline round and inverted, all hernial site intact, all quadrant were moving equally with respiration, no visible pulsation, peristalsis, no scar marks, no discoloration in the flanks around the umbilicus, no localized swelling, no presence of cyanosis, no loss of pubic hair.
Okay. Shape of the abdomen, it's normal, not distant. So there is no abdominal distension.
Yes, sir.
Okay. Usually, if abdominal distension is there, what are things you should think of?
So if there is abdominal distension, then we have to suspect there might be ascites and there might be intestinal obstruction as well.
Okay. So you should look for symmetry and asymmetrical organomegalies also. Okay, asymmetry is there. And fat also, normal fat also. Okay. Those things. Venous prominence. What is important on venous prominence?
Sir, if there is any aneurysm.
Yeah. Any IVC obstructions. Okay.
Yes, sir.
Infravenocaval obstruction and supravenacal obstructions. Then portal hypertension also. What is caputo medicine?
Dilatation of vein, sir.
Dilation vein around the umbilicus. It's like a
Yes.
capite. Okay. Then all umbilicus, normal umbilicus, how it will be?
Normal will be central in position, midline, round and everted, sir.
Yeah, inverted. It will be inverted and retracted.
Yes, sir.
Okay, if it is everted, any is there, then umbilical hernia, intense ascites and all, it can cause umbilical hernia and all, it will be there. Okay, so all quadrants are moving equally. That is very important. If quadrants are not moving equally, then you should think of organomegaly also. Okay, in a hepatomegaly, splenomegaly, then that quadrant will be reduced. Inspiration, that movement should be reduced. How will you divide the quadrants of abdomen?
Sir, on the basis of two lines, sir. That is passing from supraclavicular line.
Mid clavicular, no?
Mid clavicular line, yes, sir.
Okay. Okay. There are one more thing is there. How will you differentiate areas? There are 4 quadrants: upper quadrant, lower quadrant, right upper quadrant, left upper quadrant, and right and left. That is quadrant you divide. How will you divide regions? There are 9 regions, no?
Yes, sir. From the one from the titubal region, sir, and one from the anterior superior iliac spine.
Yeah, yeah. So right hypochondrium, left hypochondrium, epigastrium,
hypogastrium.
Okay, yeah, those things. So according to that, you can tell if dilated vein is seen in right hypochondrium, you can mention that. Okay, and if any scar is there, that scar is present in the left hypochondrium. Like that, you can mention according to that area. Okay. Okay. Any discoloration is there? What discoloration? Usually there are 2 signs. No, what is that?
Sir.
Gray Turner sign, Cullen sign.
Yes, sir.
So usually in pancreatitis,
yes,
yeah, pancreatitis, you can see those signs around umbilicus and right or left lumbar region. Okay. Then, so yeah, as inspection, everything is normal.
Yes, sir.
Okay. You should ask if any tapping is done. That maybe scar mark also will be there. Okay, mild scar mark will be there. The insertion of the needle will be there. No, that mark will be there. Okay. Next. So continue.
On palpation, no local rise of temperature. Abdomen was soft. No tenderness all over the quadrant. On deep palpation, no organomegaly. Palpable liver. No palpable liver.
Okay, you can't able to. Okay, you can mention palpable liver, but you have to measure. Can you tell me the measurements and all?
Measurements.
Abdominal measurements. Okay, palpation. First, you should think local rise of temperature. If temperature is raised, then you should think of SBPR, any abdominal muscle cellulitis, anything like that. After that, local rise of temperature, you should tell about the tenderness. So tenderness is very important. Okay, where all which and if right hypochondrium tenderness is there, what is your inference?
Sir, liver might get inflamed.
So hepatomegaly, liver abscess. Okay, yes, severe hepatomegaly, liver abscess, congestive hepatomegaly because of heart failure. Those things are tender. It will be tender. Okay, then gallbladder, acute cholecystitis. There also you can see tender. If epigastric pain is there, epigastric tenderness is there.
If all the 4 got derivative will be aspirin at epigastric region. So
yeah, peptic ulcer disease almost everything will be referred. Then pancreatitis also. Usually in pancreatitis, umbilical and epigastric area, it will be tenderness will be there, and there will be forward bending, no, relaxingly,
Yes, sir.
forward bending sign. Okay, that you should know. Then tenderness in left hypochondrium. We should think of
Left
splenic abscess, splenic influx, and massive splenomegaly. Those things you should think. Okay. If any tenderness is present in lumbar regions,
lumbar means then
renal
spleen.
stones. Okay.
Yes.
Renal angle, backside renal stones. Okay. Renal stones and hydronephrosis, any obstruction of ureter, those things and all you can think, and and the polycystic kidney disease. Those things you should think of. Okay. And if tenderness is present in right ilia, that is very common.
That appendicitis, sir.
Yeah, appendicitis. Yeah, appendicitis, ileitis. Then if it is present in hypogastrium,
On hypogastrium, then we can suspect
UTI, normal UTI,
yes,
urinary tract infection and all. If it is in the left hypogastrium, you should think left hypochondrium, left ileum, left iliac region. Then you should think of diverticulosis. Okay, rectal
yes,
infection. Okay, those things and all. Okay, so the quadrants and the areas you should tell tenderness area. Okay, then organomegaly. Will you palpate liver?
sir. Liver on stand on initially we have to stand on the patient right side. Start palpating. We have to start from right iliac fossa, and we have to ask the patient to take a deep breath and gently push our hand inward and upward, and we have to trying and antiseptic to feel the liver edge as it comes during inspiration. We have to tell the patient to inspire the air, then we have to palpate. If then we have to gradually move our hand up inch by inch, and we have to repeat the process until we feel the liver edge or costal margin.
Okay. Okay. How will you palpate spleen?
Spleen can be we have to again we have to stand on the right side, and we have to place our hand left hand behind the patient left side under 11 and 12 ribs area, and we have to ask the patient to take a deep breath and gently push our hand inwards and upwards, left upper quadrant across umbilicus, and we have to trying to feel the spleen as it comes down towards the right iliac fossa during inspiration. So we have to feel. We have to ask the patient to inspire, then we have to feel the spleen.
Okay. What is the second method for palpating spleen?
Spleen, sir. We can diagonally also we can go.
Yeah, we on standing left side we can do one method. No, what is that method called? A named method. That is called Middleton's maneuver. That is and also called hooking method. Okay, so you should stand left side, facing towards legs. Okay, so you should hook the ribs under the ribs and tell him to tell patient to take deep inspiration. If spleen is then if and after taking deep inspiration, spleen can be touched by touched to fingers when you are hooked. Okay, if the spleen is touched, then you can think of as mild spleen enlargement is there. Okay, that is called Middleton's maneuver. Hello.
Yes, sir.
Yeah. Then how will you palpate kidney?
Kidney, sir, we have to place two. Initially, we have to ask the patient to put sleep on supine position. We have to place one hand on abdomen region and one hand on back region. Then we have to press gently from the upper end. We can feel the kidney, sir.
Palatable. Yeah, palatable. Okay.
Yes, sir.
So we have to differentiate kidney and spleen. Okay. So spleen enlargement will be diagonal towards the umbilicus. Kidney will be downwards, towards the left iliac. Okay. So like that, you can differentiate kidney mass or splenic mass and all. Okay. Then next.
On CNS examination.
No, palpation. One more thing is there. No, palpation measurements is very important. Abdominal girth measurement. Okay, around the umbilicus, we should measure the abdominal girth for especially ascitic patient to know the reduction of ascites. So if fluid is coming down or not, we should see. For that, you should measure girth of the circumference of the abdomen. You should measure. Then one more thing, sternum to umbilicus to pubis measurement also we should do. Is it umbilicus is central or it is pulled downwards or pulled upwards, to measure that also. And to know the asymmetry of the abdomen, to know that asymmetry between umbilicus and anterior superior iliac spine, that right side and left spino-umbilical segment, you should measure that measurements. Okay, if it is equal, there is no organomegaly. If it is unequal, sometimes organomegaly is there and all. We can see further. So palpation may organomegaly, organs palpation, then measurements also important. Okay, abdominal girth is very important to see the prognosis. Is it resolving or not and all. Okay.
Okay, sir.
After that, percussion. You should do percussion. No, did you not do?
Yes, I have did. I think I have did. I have did there, sir. I have forgot to place this on this
Okay,
page.
okay, okay. Percussion. Okay, I will only tell percussion. What all the headings will be there? Usually, percussion.
Yes, sir.
First one is a tidal percussion. You should do to look for the upper border of the liver. What is tidal percussion?
Sir, we have to. If there is any fluid, sir.
Yeah, upper part of the liver. You should percuss from the second intercostal space. Go on percussing. First, you find the dullness. If you find the dullness, then you should think of some liver pathology or lung pathology, and or it is a normal upper liver border. Usually, upper liver border will be fifth or sixth intercostal space. Then you tell the patient to take deep breath. When patient take the deep inspiration, then percuss again. If the dullness is still present, then it may be consolidation or pleural effusion, the lung pathology. So if it is resonant, then it is the upper border of the liver. So that's how we will detect the upper liver border. Then after that, you can detect the liver span. You will be knowing the upper liver border. Then lower border you are already palpated. You can measure that. What is the normal liver span?
If you were fifth intercostal space too, sir.
Yeah, normal liver span will be 8 to 12 centimeter usually. Okay.
Yes, sir. Yes, sir.
So if it is more than 12 centimeter, you can call it as hepatomegaly, but it differs from different adults also because of the height of the patient and all. It will little bit deviates also that measurements. Okay.
Yes, sir.
Okay. Then after that, you should think as if ascites and all is there, you have to do for shifting dullness. You know shifting dullness, no? How to detect shifting dullness? How to do shifting dullness? Then fluid thrill. If shifting dullness is present, then around 1000 ml of fluid is present. If fluid thrill is present, then shifting dullness won't be present. If fluid thrill only present, then the amount will be 2000 ml. Okay. What is puddle sign?
Vital signs.
Puddle sign. PUDDLE puddle sign. What is puddle sign? So when you should tell the patient to first you should percuss on the around the umbilicus. It will be resonant. If it is mild ascites is there, you tell him to dog knee position. Okay, you should tell him to dog knee position. During that time, you just again you percuss the umbilicus. It will be if it is mild ascites, it will be then it will turn into dullness. Usually less than 100 ml till 30 to 100 ml you can detect like this if fluid is there or not. In ultrasound, less than 30 ml also you can detect. Okay.
Yes, sir.
Hello. Okay.
Yes,
Then
sir.
how will you percuss for spleen?
Spleens are.
There are two methods, named methods: Nixon's method and Castle's method. Okay. In Nixon's method, you should tell the patient to lie on right side on supine position, and you should percuss from posterior axillary line perpendicularly to the umbilicus. So if dullness more than 8 centimeter, then spleen enlargement will be there. Then same thing, Castile method, you should percuss in supine position, anterior axillary line. Usually it will be resonant. If dullness is there, then spleen enlargement will be there. Okay.
Yes, sir.
Okay. Next, continue.
On CNS, sir. Oriented to time, place, and persons.
Then auscultation of the abdomen. So
Yes, sir.
auscultation of abdomen is important only. So usually normal bowel sounds, 5 to 10 sounds will be bowel sounds will be movements of the intestine will be heard. So if it is absent, then you should think of paralytic ileus, any perforation, anything like that. So if it is more increased, usually in obstruction and all, sometimes a small intestinal obstruction, it will be increased. Okay, in abdominal ascites also, it will be decreased.
Yes,
Okay,
sir.
so auscultation is important in abdomen. Okay, then
I have forgotten that, sir. Bowel sound was heard on 6 per minute.
yeah,
There
yeah.
was
Then
no
it's
hepatic.
normal. Then
Yes, sir.
it's normal. Okay.
There was no hepatic root, splenic rub,
Hmm,
auscultatory percussion was absent,
hmm.
and, and that things are on auscultation.
Okay. Then next.
Sir, on CNS examination, sir,
Hmm,
oriented to time, place, and person, normal speech, normal recent, remote, and immediate memory, motor
hmm,
sensory within normal limit, reflex normal, tone normal.
hmm. So main thing is, as I told, no CNS में you should check for constructional apraxia.
Yes,
So
sir.
hepatic encephalopathy, no early sign. So you should tell him to write structures. Okay. So reflexes. If patient is in stage 1 of hepatic encephalopathy, reflexes will be brisk. So stage 2 and all in coma and all, it will be placid. Okay. Tone also. So usually it will be spasticity will be there. Usually in stage 1 way. Stage 2, if patient goes for coma and all, it will be flaccid. So tone will also will be decreased, and memory also will be disturbed. That is also anyway is not there. Only early stage, because altered sleep pattern is there. Early stage is there. Okay. Then
Then we have to do for tone and tone, sir, and
yeah,
then
tone.
motor and sensory was in normal limit.
Okay. Next. So this is a okay. Next we can go forward.
Okay, sir.
CVS examination.
There was S1, S2 was hot. There was no any murmur.
Okay, in chest RS examination also bilateral vascular sound. Okay, fine. There is no creps and all, nothing, no decreased breath sounds and all.
Yes, sir.
Okay, okay. Then usually in CVS examination, if hepatic failure, any hematemesis and all is there, severe in septic, that time it will be tachycardia, any hemic murmurs and all will be there if severe anemia is there and all. Otherwise, it's not much related to this case. Okay, RS also, if any pleural effusion, fluid overload and all is there, then will decrease breath sounds and associated complications, pneumonia, anything like this. Then Krebs and all will be there, consolidation things, dullness, those things and all. Otherwise, it's not that important. So you can continue.
Now, my summary of the history.
Mm,
55-year-old farmer by occupation, Hindu,
mm,
presented
mm,
with vomiting of blood since 9 days and lowest
mm,
discoloration of eyes since 7 days, with
mm,
malaise and weakness. Similar
mm,
illness on past. On examination, pallor was present, icterus was
mm,
present, spider
mm,
nevi was present, flapping tremor
mm,
present.
mm. Okay. Then, so
With
what is
this,
your diagnosis
my
with this?
provisional diagnosis is chronic liver disease,
Mm.
and with mild uh, bleeding from the uh,
No, chronic liver disease with signs of hepatocellular failure, with early stages of portal hypertension, with early stage of hepatic encephalopathy. Okay, the complications are there, no? So
yes,
chronic
sir.
liver disease and portal hypertension ka hematemesis is there. Okay, we don't know splenomegaly, hematemesis is there. It may be portal varus or peptic ulcer disease also can cause early stages of portal hypertension. Then flapping tremor is there and sleep pattern is there. So it may be hepatic encephalopathy, grade 1 or grade 2. Okay, grade 2 hepatic encephalopathy. So if these two are there, then it's a hepatocellular failure. Okay, so chronic liver disease with hepatocellular failure with hepatic encephalopathy grade 1 with early stages of portal hypertension. This is the proper diagnosis. Etiology will be, as you told, alcoholic history is significant. So it may be alcohol induced only. Okay.
Okay, sir.
Hello?
Yes,
Okay.
sir.
Okay. Next.
My provisional diagnosis is chronic liver disease. with
Yeah, you should mention all these things: chronic liver disease with early stages of portal hypertension with hepatic encephalopathy. So, and signs of hepatocellular failure. Okay,
okay, sir.
okay, and etiology will be alcohol in this case. Okay, so what are the causes of chronic liver disease?
The causes of chronic liver disease are alcohol uh, and Wilson disease
Okay,
and uh, Wilson disease, hepatitis, viral hepatitis, non-alcoholic fatty liver
what
disease,
viral hepatitis will cause?
hepatitis B,
Okay,
mainly hepatitis B and A and C.
usually hepatitis B and C. Okay, A won't cause A and C. Then
Alpha 1 antitrypsin deficiency,
so
hereditary.
you
Yes, sir.
so causes of cirrhosis of liver, viral hepatitis, alcohol, non-alcoholic steatohepatitis, hepatitis, that is called NASH, which we won't diagnose properly. Then metabolic causes like hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, galactosemia, Fanconi syndrome. Then
Yes, sir.
hepatovenous outflow obstruction like Budd-Chiari syndrome, veno-occlusive diseases, and constrictive pericarditis. Then toxins and drugs like methotrexate, imidazole. Then there's primary biliary cirrhosis and cystic fibrosis. Then congestive heart failure. Then if there is no cause, then we will call as cryptogenic. Okay.
Yes, sir.
So when the alcohol quantity is not serogenic, you should look for all these causes. Okay.
Okay, sir.
Usually serogenic dose of alcohol is 180 grams of ethanol per day for 25 years. That is almost like 6 times the safe limit. Okay.
Okay, sir.
Okay. Then how will you investigate? Next slide.
Yes, sir. Sir, on investigation, I will send for if initially I will send CBC, sir, RFT, LFT,
Mm.
and I will send uh, if the
Okay.
I yes, sir.
Yeah. So if you're already diagnosed as chronic liver disease, so alcohol liver disease, so he has presented with I am talking about this present case. Okay, he has presented with complex hematemesis, and the first thing is you should look for CBC, HB, hemoglobin. How much is his hemoglobin? If it is less
4.0.
than, if it is dropping more than 1 gram and all, you should recurrently we should do. Then we should aggressively transfuse the blood and all. Okay, if it is not dropping, if HB is persistently like less than seven, more than seven and all, so there is no need of immediate transfusion. We can wait. If it is less than seven, we can do the transfusion. Usually, if then CBC, three things are important: HB, hemoglobin, and total leukocyte count. We should look for leukocytosis or leukopenia. Any infection is there. Then
Yes,
thrombocytopenia. Thrombocytopenia is the one of the sign of liver cell failure. Okay, if thrombocytopenia is there, then in liver LFT, you should look for enzymes AST and ALT. Usually, in liver disease, alcohol liver diseases, AST will be more than ALT. Okay,
yes, sir.
okay, and then if it is hepatitis, ALT will be more than AST, and GGT also you should look for. Usually, if it is chronic liver disease, ALT, AST will be like more than 1 or 2 times of the normal value. It won't be. It will be less than 100 only. It won't be more than 100 and all. If it's acute liver failure, it will be more than 1,000. Okay, in toxin and drugs acute that time. And bilirubin also, if it is chronic liver disease, severe jaundice and all, it may be 30 and all will be there. So if in stage C, and you should grade according to after this investigation, child puck, no child puck classification, modified child puck classification.
Yes, sir.
So you can grade that one. And one more, then after that, albumin is important in liver function test. If hypoalbuminemia is there, that is also sign of hepatocellular failure. Okay, chronic liver disease. Then bilirubin, conjugated bilirubin or unconjugated bilirubin, you should look for that also. Then PTNR, PTN is prothrombin time is very important. If prolonged prothrombin time is there, then coagulation defect is there. INR is also you should see for that. Then we can see for RFT as if renal dysfunction is there, you can think of hepatorenal syndrome. Hepatorenal syndrome is like diagnosis of exclusion, like all the causes of you should rule out all the AK and diuretics history, drug history, everything you should rule out. Finally, only you should think of hepatorenal syndrome. Okay, normal diuretic induced AK also can cause hepatorenal syndrome and all. Okay, then we should look for ammonia levels. Hepatic encephalopathy, if hepatic encephalopathy, elevated ammonia will be there. Then after that, ultrasound we should look for liver size and all. Okay. Then finally, liver biopsy is to confirm the diagnosis. If you have any doubt, if there is no alcoholic, that serogenic alcoholic history is not there, then you should go for liver biopsy. Then serum copper levels, serum iron levels, ferritin levels, those things, and autoimmune causes also you should rule out, ANA screening, those things and all you should do. Okay. Then how will you treat this patient?
Sir, I will treat according to etiology, sir. If he is suffering with esophageal
No.
paresis.
No, first you should go for endoscopy.
Yes,
Every metabasis patient, you should go for endoscopy in this patient. Okay. Anyway, in acute presentation, we should treat according to emergency care. You should think of portal gastropathy and portal esophageal varices also. If it is portal gastropathy, we can start antacids, Pantaf infusion and all. Then if it is varices bleeding, if we think of that, if you suspect that high risk of variceal bleeding is there, then you should start vasopressin analogs, terlipressin, okay, and octreotide. If those things are not available, noradrenaline also you can use. Okay. Then beta blockers also you can use. Okay.
yes.
Then endoscopy you should do. If it is not coming, bleeding is not coming down, you should take emergency endoscopy. You should banding, ligation. Then also sclerotherapy you can do. Okay.
Yes, sir.
Okay. Then next.
If hepatic encephalopathy, we can give lactulose or rifaximin.
Yeah. So lactulose, how it will help?
Lactulose acts by converting ammonia into ammonium ion.
Yeah, it will decrease the ammonia, and also it will by then sorry, forgot how it will.
Yes, sir.
Rifagat tablet.
Rifaximin, yes, sir. It will decrease ammonia production by gut flora.
Yeah. Okay. Okay. Then
if there is hepatorenal syndrome, then we can do liver transplant.
No, liver transplant. That's what. No, you should child puck scoring and all you should do. Okay.
Okay.
What is child puck score? There's 3 stages. No.
Yes.
Sir. Five components are there. What are the components? Oh, that's serum albumin.
Yes, sir.
Encephalopathy degree, ascites, bilirubin levels, albumin, and INR. Earlier it was prothrombin time, that is PTA. Okay, there are 3 grades, 1, 2, 3 scores are there. If score is 5 to 7, that's class A. Is suitable for surgery, and class B 7 to 10 is marginal surgery. The TIPSCA. Then class C is more than 10. He won't be is unsuitable for surgery also. Okay.
Yes, sir.
In acute settings, we can't do liver transplantation. So in advanced liver disease, we can get them for liver transplantation. Okay.
Yes, sir.
Okay. So, any doubts?